All right, everybody, we are going to pick up where we left off with pharmacology. We're going to talk about medication distribution. I'm pretty sure today, let me move quite far through this. So you guys are doing great. I'm sorry it won't let me. For some reason, I have a really old version of Windows, so it doesn't necessarily let me just move on like the Google Slides. I can go from where I am. Okay, so distribution of medications. Things that determine distribution of medication would be the chemical property of that particular medication, physical properties of the medication in the patient, and then physical properties of the medication as well as patient factors. There are multiple different barriers that may prevent the introduction of foreign substances into the body. Medications are considered a foreign subject. It's not part of your body. So sometimes there are barriers that help that prevent that or speed up the process of that medication being introduced into the body. Osmosis, you guys should know that osmosis is used to enhance the distribution of certain medications. Osmosis, you guys know what that is. I'm not going to revisit that. You've been over that in biology. You've been over it in chemistry and physics most likely. So I will not go over osmosis in depth again. But just know that IV fluids give us the opportunity to allow medications to get into tissues, into intervascular spaces, and also into other cells and stuff at a more cells and other parts of the body at a more rapid pace because it goes directly into the bloodstream and it's not being passed through the GI tract or through fatty tissue or into the muscle specifically. Filtration, do know what filtration is. That's the process within the body that's used to redistribute water and other particles. Filtration is basically when the body takes a substance in and it takes kind of out the things it doesn't need, but it gives you back what you do need. Hydrostatic pressure forces various fluids against the semipermeable membrane, which causes some things to be able to flush through, some things not to be able to flush through. Just remember, though, that filtration is the process where the body redistributes water and other products, other particles within the body. Epithelial cells create our continuous barrier. So our skin is our continuous barrier. Small, non-ionic, and lipophilic molecules pass through the cell membrane. So a lot of you guys have had some anatomy or you've had biology, and you know that epithelial cells have a bilipid membrane. And some part of the bilipid membrane, the heads are hydrophobic and the tails are hydrophilic. So parts of them, that's what helps them attract to each other. Larger hydrophilic and ionic molecules must pass through another route of entry. So sometimes things can go through the skin, like we can absorb certain types of medication through the skin through an ointment or a cream or things like that. But for the most part, lots of times we have to put them in through another route of administration, and that would be through active transport, through facilitated diffusion, or pinocytosis. Those are other processes in which larger hydrophilic, and so what does hydrophilic mean? You guys think about that. Hydrophobic would mean it does not like water. Hydrophilic would mean it does like water. So those are other ways or other routes for entry, and that would be why we would need those. Medications must go through the capillary wall to reach some tissues. That means that there are 3 barriers that need to be that they could potentially pass through. So narcotic medications definitely pass through the blood-brain barrier. Any kind of nervous system medication is going to pass through the blood-brain barrier. And we need to think about that because if someone has pressure on the brain, we want to make sure that the medication that we give, once it passes the blood-brain barrier, it doesn't increase pressure or increase issues. We also need to know that sometimes when we give medications that pass the blood-brain barrier, it may affect their level of consciousness. Also, we have to think about if someone is pregnant, will that medication get to the baby? Will it pass the blood placenta barrier? Will the baby have to filter and absorb and take on some of the properties of that medication? How is it going to affect the baby? And then there's the blood testes barrier does, and that's kind of like with hormones, as a way to think about that with hormone therapy. How does it impact that? Plasma protein binding. So we've talked a little bit about receptor binding. Now let's talk a little about plasma protein binding. Plasma is part of your blood products. You have red blood cells, white blood cells, platelets, and you have plasma. In plasma, there's a lot of particles. There's lots of proteins in there. And medications sometimes need to be transported through blood plasma. They don't necessarily attach to the red blood cells, the white blood cells, or the platelets. They may transport around in the blood plasma. And so sometimes the concentration of proteins, because they need to bind to that protein to be transported, sometimes the protein level in the body, if it's very low or very high, may determine how well that medication is actually transported throughout the body. Some proteins, even though they're available, will not allow binding of particles. So we have to be sure that a patient, if it's a protein binding medication, that a patient can actually handle that. Lipophilic medications can be sequestered in the fat tissue, especially of an obese person. So that means the medication is really revealed if someone's overweight and they're a lipophilic, that means they're attracted to fat cells, they may distribute that medication more slowly, and it may take longer for it to actually affect the body. So just be sure that if it is a medication that is stored up in the body fat, so some vitamins and minerals are stored in body fat. There are certain medications that do the same. So we have to know that if someone's extremely obese and we need a relatively quick effect, we may have to do a loading dose for that person to get them to that concentration that we need. And then we can back that dose down to a normal dose, to a daily dose after that loading dose. Lots of times loading doses are a high, sometimes double or triple what the normal dose will be, and then they get back down to that normal dose level, so that it can maintain a steady amount or a steady concentration in the body. Volumes of distribution. So that describes the extent to which the medication will spread within the body. So the volume of distribution means how much are you actually going to have in your body once the medication gets to where it needs to be. Medications with lower volumes of distribution usually have a higher level present in the plasma. So that means it's still in the plasma, and the body has to go filter that out because it's more than it may necessarily need. Biotransformation is when a medication becomes a metabolite. An active metabolite is capable of changing a cell's activity or being pharmacologically active. So an active metabolite actually does, it alters the cell's activity or alters body function. Inactive metabolite is when the body can no longer use it. It no longer affects the function of the body, and the body just is going to need to excrete or get rid of that. Possible effects of possible things that may affect biotransformation. An inactive substance can be activated. So sometimes medications may have a substance in them that's not activated until it goes through a certain process of breakdown. So some medications aren't active. Some medications are active as soon as you put them in your mouth. Some medications are active as soon as they hit your stomach, like a proton pump inhibitor. Some medications aren't active until they go into the liver. So we've got to know when that inactive substance, where it will become active. An enteric-coated aspirin doesn't start to break down until it gets into the intestine. An active medication can change into another active medication. So sometimes we give a medication along with a medication, or there's two properties in a medication to make one more active. And then at some point, sometimes different things in the body or other medications or if a receptor site is unavailable, then that medication can be inactivated. An active medication can be transformed into a substance Sometimes that we have active medications or active metabolites need to be transformed into another substance so they can be easier utilized and then more easily eliminated once they are no longer bioactive. Most biotransformation occurs in the liver. I want you to remember that. The kidneys, the lungs, the skin, the GI, and other tissue can also cause biotransformation. So make it bioactive, make that able to be used in the body. Those are things like through your skin would be ointments and lotions. Through the lungs would be respiratory meds. The GI tract would be things like an enteric-coated aspirin. Diuretics affect the kidney and they're biotransformed in the kidney. So just know that those are also things that can happen. Most medications are primarily removed from the body via the kidneys. Now, remember that stool or bowel movement is 95% bacteria and about 5% water and food waste, where our urine has a high concentration of metabolites or inactive metabolites along with other waste from the body and water. So there are two patterns. Zero order elimination, that is a fixed amount of a substance that's removed over a certain period. And then there's a first order. And that means the rate of elimination is influenced based on how much there is in the plasma. So no zero in first order elimination, and know that most elimination takes place in the kidneys. The half-life of a substance, that is how much time does it take from the time that the body the body activates the medication when it's bioavailable. How much time does it take for 50% of that medication to be utilized and eliminated from the plasma? So half-life is basically that. When half of the medication amount is available in the body. Things that can alter that, disease processes, perfusion issues, cardiac issues, and then interactions with other medications. Those are things that can either increase or decrease the half-life of a medication. Medications are administered at a dose and a frequency equal to the body's rate of elimination. So when we talked about the monographs, that means that the monograph in there will discuss how quickly, it'll discuss half-life, it'll discuss frequency of dose and how it should be best administered. And it will also give you information based on disease process. We don't want to give someone a medication and it build up in their body to a point where it causes one of those things we discussed earlier, the toxic or the fatal level of the medication. So we have to know at what rate is the body supposed to get rid of it. And then based on disease processes, how is that rate going to be altered? Sometimes we need to be mindful that sometimes parts of the medication is eliminated in the air. Breathing treatment, oxygen, inhalers. Sometimes as we administer those meds, part of that medication actually escapes. And so sometimes we have to factor that in when we're administering a medication. So we have discussed to no end, but we'll discuss one more time, the issue with medication errors. Our job is to prevent those or lower or understand how to decrease that. Medication decisions are often based on what we know. We have to know that a normal dose for someone brand new to metoprolol generally is 25 milligrams. And that they should take that depending on the release consistency of it once or twice a day. Know that this is one of the most stressful parts of life as a healthcare worker is making sure we understand a patient's meds, we understand what's going on with the patient, and that when we treat that patient, we're treating them in a way to prevent life-threatening issues. Now, this discusses the rights of the patient. We have talked about this before. We talked about medication when we talked about medical math, but we're going to review it again because I can't, and you will see this again, the 6 rights of the patient. That is for them to be able to for the medication to get to the right patient. It is easy in a large setting when you have a lot of patients to grab a medication and go give it to the wrong patient. So you have to verify the patient at least by 2 forms. Then the right medication, you want to make sure it's not just the right, that you're pulling the right medication out of the med cabinet. You don't want to house things next to each other that could be mistaken for one another. It's an easy way to make a med error. That you're given the right dose, that your calculation is correct, it's correct with the doctor's order, and that you have verified it as well. Have someone double check it if you're worried about it. The right route. Did he order it IM, IV, PO? How am I supposed to give that medicine? And I'm making sure I gave it the right route. Also, the right time. You only have if you're in a hospital setting, you have an hour window, 30 minutes before and 30 minutes after. Also, if a doctor orders a medication stat, did I give it as quickly as possible, or did I see 3 more patients before I gave it to them? Did I room 3 more patients before I gave it to them? You want to make sure that the time is appropriate and that the patient is not getting a double dose of that medicine. Also, that I documented it or reported any issues. I followed up on that medication to make sure it did what it was supposed to do. Those are definite ways we can reduce med errors. It's just by making sure we follow the 6 rights for a patient. And other ways to reduce medication errors. There is the Institute of Safe Medicine Practice. It develops a list of medications that are prone to be given inappropriately simply due to the way it's written. Once again, we don't use trailing decimals like 4.0. We wouldn't write 4.0. We would just write 4 milligrams. That way, it's not someone doesn't not see the decimal and we give them 40 milligrams instead of 4. Also, we put a 0 in front of a decimal like 0.8 or 0.4 milligrams. That way, we're not giving 8 milligrams or 4 milligrams. We don't abbreviate morphine, magnesium, subcutaneous. We write it out. Intranasal or intramuscular. Those can be they can be mixed up. So there are things that we do not. We just don't. We don't abbreviate units as a U anymore. We write out units. So just know that there are things that we don't abbreviate because it will cause a medication error. Medications used in respiratory management. So we talked a little bit about beta 1 and beta 2 blockers, but we'll talk a little bit more. Primary treatment is for someone with an asthma attack or other bronchodilation issues, COPD. What beta agonist medications, what they do is they target some target beta 2, some target beta 1 and 2 receptors, and they allow those bronchospasms that they're having or that shortness of breath that they're having related to COPD or asthma attack allows that breathing, the muscles in the bronchus, it allows them to relax and to have better and smoother breathing. Albuterol is a selective beta 2 agonist. So albuterol was actually one of your medicines on your very first test list for Friday. So it's a selective beta 2. It's usually given in a nebulizer, but it can be given in a metered dose inhaler. It's usually what's in the little handy haler or the little metered dose inhaler that's given that we give asthma patients and COPD patients when they're having an acute attack and they need medication quickly. Levobuterol is similar to albuterol, but it has beta 1 effect, so it affects the beta 1 part. Terbutaline and epinephrine are also given. Racemic epinephrine, it can be given in a breathing treatment. Terbutaline is something that's actually a respiratory medication to help relax the bronchospasms, and that's what it was originally set up to do, to be utilized for. But if you remember, sometimes we use medications for things that they're not necessarily FDA approved for. Well, one of the things that terbutaline is also used for is preterm labor. So terbutaline will cause a lower blood pressure, an elevated heart rate, just like epinephrine will. but it'll also relax the smooth muscle in the uterus and prevent contraction. So it affects cells, not necessarily just like epinephrine. It's going to affect things that are not just necessarily the lungs. It's going to affect other parts of the body. Mucinetic and bronchodilator medications, Atrovent, which is another one of those medications you had, iatropine, it antagonizes those mucus producing cells, and it helps thin out mucus, decrease the production, and allow more air to go in through the airway. Steroids are another thing. Corticosteroids. There were a couple of corticosteroids on your list. We use those for multiple things. Corticosteroids are used sometimes for respiratory treatment. If you're having an allergic reaction, if you are things like dexamethasone and prednisone and solumedrol are some meds that are used, IVIMPO, to help with respiratory issues, help slow down the inflammatory process in the lungs. But corticosteroids can also be used in chemotherapy type treatments because they have immunosuppression properties. And so sometimes we have to be careful about who we give corticosteroids to. You have to be very, very careful if someone is an HIV patient or a Hep C patient or has some other kind of reason that they are immunocompromised. Be very careful about giving excessive amounts of corticosteroids. You can actually do steroids as a breathing treatment as well. Antidysrhythmic medications. So those are to help the heart maintain a better rhythm. So sometimes people have AFib or they atrial fibrillation or they have frequent PVCs or supraventricular tachycardia, and we give these medications because they target specific cells within the heart that help convert the rhythm and help them have better contraction of the heart, appropriate contraction of the heart to change that rhythm back to a normal what it should be. So there are 5 classes of cardiac cell activity. Phase 0 is when the heart's at rest. Phase 4 is when the heart's at rest. So let's start with phase. So that's when the heart's at rest is phase 4. Phase 0 is when the heart gets an influx of sodium ions in so that it can contract. Phase 2 is when those sodium is pushing the potassium out of the cell, and then calcium also helps involved, and then the calcium movement increases and causes outflow of the potassium. So basically it's that. Hopefully you guys learned in your previous classes action potential. That's really what's happening there when that cell is polarizing, the heart is polarizing and repolarizing. Those cardiac cells are in a place of polarization, depolarization, and that's when the heart's contracting. And those particular medications for those dysrhythmics are antidysrhythmics. They help change that action potential in the heart. That's what I want you to remember, is that those antidysrhythmics, they change the action potential in the heart. They make it work effectively and appropriately so the heart is pumping the way that it should. Class 1 antidysrhythmic medications slow the movement of sodium in the cardiac cells. Procainamide is one of those medications that suppresses the activity of how the conduction of the heart is, the velocity of the conduction. Lidocaine blocks the sodium channel. So when we give someone lidocaine, you guys think about lidocaine probably most often because you think of when you get a cut, it also has numbing properties. So we give lidocaine to numb things. Like if you're going to get stitches, we give lidocaine in there. If someone's had to have something opened up because it was infected, sometimes we'll give lidocaine to numb that up. Lidocaine also is given in an IV form in a much larger dose to help with ventricular dysrhythmias, so that it can make sure that if you're having extra beats, those kind of smooth out. That's what those ectopic foci are. That means extra beats or irregular beats or beats that are out of the normal rhythm. Class 2 anti-dysrhythmic medications are adrenergic blocking agents, and they inhibit catecholamine action. So catecholamines are activate beta receptor sites, and so they can cause if they're not working appropriately due to the calcium channel, due to patient being on a calcium channel blocker, they can cause really big conduction abnormalities. Now, hopefully you guys remember how the heart works, some from previous science classes. So you know that the heart has to be able to the sinoatrial node fires, and it makes the atrium contract, and then it sends a signal to the atrioventricular node, which makes the ventricles contract. Well, sometimes beta adrenergic blocking agents and calcium channel blockers together will mess up, or they'll interfere with that conduction process of the heart to make it contract appropriately. So we have to be aware if patients are on different medications. A class 2 antidysrhythmic that's used very often in healthcare is metoprolol or low pressor. It reduces the heart rate, especially during heart attack and post-heart attack, someone who's had a heart attack, or someone that has atrial tachycardia, which means their atrium beats too fast. The top parts of the top two chambers of the heart, they beat too fast, and they're beating faster than the lower. It's not necessarily atrial fibrillation or atrial flutter. It just causes premature atrial contractions. And so that metoprolol or that low pressor will help slow a heart rate if it's beating too rapidly, but also increase blood flow and oxygenation to the heart, and then help with atrial if their atria are having some extra beats. Class 3 antidysrhythmic medications, they prolong the refractory period. That means that it can treat atrium or ventricular tachycardias. One that's given the most often is amiodarone or cortisone. It can be given PO or IV. It can be given continuously until a cardiac or until a heart rhythm converts, and then they'll switch the patient over to a oral dose. And then the one thing about this, though, it can cause other cardiac effects like pulmonary hypertension, and it can cause respiratory issues as well. So just know that medications like amiodarone or cortisone is the brand name. They do cause they have some pretty significant side effects. Oops, sorry guys. Let me see, how are we doing on time? I know that, oh, my little timer's on the other side, sorry. So we're at about 28 minutes. We'll spend a little more time here. We definitely need to, we can finish up most of this today. We are here on, okay, so I'm going to leave it here. You guys can see this, I know, because it shows you the screen the same as it shows mine, so I'm not going to click it back up or have to scroll back through. Class 4 antidysrhythmic medications, those are calcium channel blockers. Calcium channel blockers are given to patients all the time. Things like Altase or amlodipine. Benazepril, lisinopril, those are calcium channel blockers that are given very often. They have a variety of uses. When they displace the calcium at certain receptor sites, it can affect smooth muscle. And so sometimes people that take a calcium channel blocker will have a dry, hacky cough all the time. Just because of the side effect of it. And if that does happen, then lots of times they have to be changed to a different medication just because they can't sleep even sometimes due to it. It decreases automatically. It helps decrease those PVCs or PACs, preventricular or extra atrial or ventricular beats, and make a better contraction of the heart. So here's some examples of class 4 calcium channel blockers. Verapamil or Calcan, ditalazine, those are given IV usually, and they have to be administered over a couple minutes. And then ditalazine can be given continuously for a little while. Once again, then they usually switch them over to something like lisinopril, benazepril. Verapamil can be given as a pill form as well. Ditalazine or cardizem is a pill as well. They can be given IV and PO. If they're given IV, we have to watch their cardiac status very frequently. If they're given it PO in the doctor's office, we generally do need to make sure that we get an EKG on that patient at least twice a year to make sure there's not any effects. Adenosine is something that you guys may never give. Hopefully, you'll never give it unless you're a nurse or that's in part of a code team. It's the only time I've ever given it as part of a code team, and that's because I needed to rapidly cardiovert someone, and I didn't want to use. We did not want to use the AED. That AED, the patient was awake and alert, but they were going into ventricular fibrillation, and so we gave them something called adenosine, which is discussing with you there. And what it does is it will stop and restart the heart quickly. You can only give that a couple of times, and then you have to move on to external cardioversion. But that's chemical. It's used in chemical cardioversion. It doesn't necessarily have a class. It decreases cardiac conduction and velocity and prolongs the refractory period before it starts. So like I said, it causes a pause in cardiac activity. It literally stops the heart for about anywhere from 10 to 30 seconds, and then they pick back up, and hopefully when it restarts, it's in a normal rhythm. Other cardiac medications, alpha-adrenergic receptor antagonists. So they prevent catecholamines from reaching alpha receptors, which makes what happens basically with alpha-adrenergic receptor antagonists is they lower blood pressure. That's what I want you to know. They lower blood pressure, and they decrease systemic vascular resistance. So it also makes the vessels less resistant. It relaxes the vessels a little bit. They're most often given to people with enlarged prostates that have high blood pressure or with glaucoma, because we want to make sure the vessels are relaxed, that they are able to, the pressure, whether it's behind the eyes in the prostate or your vascular, the tension in the vessels are all relaxed enough to have a good output, but also to have good perfusion. Some examples of those would be catapress or clonidine. You guys had that as one of your medications. Labetalol is given. It has beta 1 and beta 2 agonist properties. Labetalol is still given fairly often, sometimes in place of metoprolol when they are not, when they are unable to. When they're unable to tolerate metoprolol. Regitine, you guys are probably never going to give that. It's not used often in the clinic setting, so I'm not really going to worry so much about that, but you will have patients on the other two medications. So what happens with an agonist? What happens is it helps convert enzymes, and basically the renin-angiotensin converting system that happens through the adrenal gland, it alters that. Therefore, it can cause the blood pressure and cardiac afterload to decrease. So doesn't push so much blood into the heart that the heart can't handle it, and it decreases blood pressure overall. Once again, like I said, sometimes they have a chronic dry hacky cough. Rarely do they experience sudden life-threatening angioedema. But if a patient is having that dry, hacky cough, and it continues after the first week or two of use of some of these medications, they will go ahead and treat them because prolonged use could cause that angioedema. And we definitely don't want them having a swelling around the heart. Anticholinergic medications, you will see that most often in atropine. Atropine affects the acetylcholine usage, and it treats bradycardia. It actually helps increase heart rate. So we give atropine to people whose heart rate has slowed down really, really low. Would be in a crash cart in your facility. Sometimes atropine is used as an eye drop, just for certain purposes, certain eye conditions. So atropine is definitely, it's an anticholinergic that's used. It's always also used before we put in an artificial airway, and as well. Okay, we are going to stop here for today. That way you can make sure you're um, caught up on your notes, because you are going to have a quiz over these two lectures tomorrow. You'll also have some bell ringers and things like that to do as well. So you guys be prepared, be studying for your test on Friday, and I hope you're having a great day. I will be back with you later. We should have probably 2 more sections of this particular pharmacology, and then we will move forward. Thanks, everybody. Have a great day.